Welcome, everyone, to today's session, Pharmacy Innovation, Navigating Headwinds in Health Systems for a Stronger Tomorrow. On behalf of Becker's Healthcare, welcome and thank you for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. If you have any questions throughout today's session, you can type those into the Q&A box you see on your screen. You will find a few engagement tools on your dashboard. Please check out those resources section and also make sure you fill out the session survey. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's session to access the recording. Lastly, if at any time you have trouble with the audio or video, please try refreshing your browser. You can also submit any technical questions into the Q&A box, and we are here to help. I'm pleased to introduce today's presenters, Brian Fitz, Chief Operating and Chief Financial Officer, UPMC Physician Services, Becky Taylor, Vice President of Pharmacy Service Line, University of Pittsburgh Medical Center, and Jerame Hill, Managing Partner, Visante. At this time, it's my pleasure to turn the floor over to our presenters to begin today's presentation.
Great. Thank you, Liz. Thank you all for joining us today. As Liz stated, my name is Jerame Hill, and over the last 3 years, I've had the opportunity to work with both Brian and Becky, both incredible leaders in the UPMC system. And at this time, I'll turn over to Brian to start our presentation.
Thank you, Jeremy. I will first start with a little housekeeping items, just to let everyone know that UPMC does engage Visante for consulting services and has a financial exchange between that. So I want to make everyone aware. And as we go to the next slide, I wanted to start with what I hope is relevant to everyone and some current market trends. And I'm not going to focus on these from the global perspective. I'm going to highlight what we're doing at UPMC and hope that it resonates and sees something for each of you as you go through this presentation. So pharmaceutical expenses. I think from our standpoint, our organization is unique in that we are a payer and provider. So on a provider side, we have $2.5 billion in annual drug expense and growing. It's usually growing about between 5 and 10% per annum. And then on our payer side, we have about 4.2 million members. About 1.5 million of those members are in some sort of pharmacy benefit plan and the expense associated with that. So drug expense across our organization is a heavy focus. And as you see in point 6, shrinking margins, how do we continue to evaluate that and address impacts across our organization to maximize that? If I think about it from a provider side initially, some of our areas of focus on the inpatient setting, what drugs are we using? How often are we utilizing them? How often in that length of stay for those patients are we also utilizing those drugs? Can we utilize them differently from an oral versus an IV perspective? All of those attributes make a significant difference in that independent cost of care for that patient stay while still delivering high quality care. And how do we reevaluate and readdress that? If you think about it, as we continue with challenges, the 340B program, all of us on this call, I'm sure in some point or fashion has our organization engaged in the 340B program. It's a major part of our organization. And with the constant changing rules in the pharmaceutical addressment of contract pharmacy and really working to mitigate that entire benefit, how do we react to that? How do we still leverage the program and its intent to allow us to continue to deliver care to the patients that need that, and in turn, generate the margin we need for delivering care? Payer and site restrictions. Our area was unique in the state of Pennsylvania, specifically Western Pennsylvania, in that we had a different payer dynamic. That is changing, and for us, payer restrictions and site of care challenges are becoming an increasing challenge, not just in pharmaceutical care, but everything from surgery and where we should perform that to then the delivery care. How do we evaluate that? How are we looking at what care delivery models are most impactful for the patients to meet them where their need is, where there is demand for us to provide that service, and how to maximize that from an efficient and effective basis so that we can generate a margin? That's becoming increasingly important as new clinical drugs are coming out there for things like Alzheimer's, and where and how do we do that? I don't know about all of your payer contracts, but in not all payer instances do we generate a margin on the care we deliver. So how do we continue to reevaluate that setting to make sure, again, we're being able to meet our patients' needs in an area where they have it, and also be able to sustain a financial margin to continue to generate that level of support to continue the care we provide. Labor is a huge challenge for us at this point. Any role that has the word technician after it, pharmacy tech, surgical tech, we're struggling to find. And more importantly, we're struggling to get people to have an interest in those roles. How do we react differently? How do we engage even from a high school level or earlier in the healthcare system and the delivery of healthcare and the engagement of people at that level, to have them understand what those roles are, how to get them in the door. Once they're in the door, realize this can be a career, and the different ladders we can place, not just in the world of pharmacy, but across the spectrum and continuum of healthcare. Those are areas we're trying to address, because the continued reliance around agency, whether it be in a nursing, pharmacy, or even physician workforce, is unsustainable from a financial standpoint. All that leads to integration, and that might mean something different for each of us on the call. Integration for us is an integrated finance and delivering system, and how do we engage with our payer and provider more effectively to maximize the opportunities there from a population health management. That may also simply mean, how do you integrate within the retail pharmacies in your own hospital to better capture patients from a 340B program? It means something different to us all, but all of us have to be looking at different attributes of how to integrate, how to find more efficiencies and effectiveness across our care continuum to make sure we can maximize those limited and shrinking margins. I'll talk about that more in future finance slides, but as you think about the advancements, again, let's just stick with the new Alzheimer's medications that are coming out. What's the reality of our world? Pharmaceutical manufacturers have spent millions and times billions to create these drugs. Payers want their patient population to have that, but they don't want to pay for it. So they're increasing authorization and denial strategies to mitigate the claims out the door from their standpoint. And we as a provider network want to deliver the care, but how can we continue to deliver care in the face of all the financial challenges that I just laid out? So it's a complicated world we live in, and we hope that some of the slides you're going to see in the future here help to provide what we're doing to address some of those concerns.
And thank you, Brian. Maybe one question while we're on this slide. And number 3, you talked about payer restrictions inside of care and how it's really starting to pick up in Western Pennsylvania. How quickly are you seeing that pick up and those restrictions come into play?
Yeah, we're seeing it a lot more from the national carriers, bringing in narrow network definitions are heavily focused in this area. In the world of surgery, we've seen it more advanced, so we need more of the cases, especially some orthopedic perspectives done in an ambulatory setting or specifically even an outpatient location across our hospitals. We're seeing that more move into the world of infusions and where we're challenged there. So again, some of our payer relationships we've had have mitigated to this point, but we're actively seeing, especially from a national carrier perspective, this coming in heavily at this point.
So pharmacy is the land of opportunity. And so while we have all of these headwinds facing us, how is the pharmacy department at UPMC, and how could it help in your facility to drive financial sustainability, be a pillar of operational excellence, and show that integrations can drive economies of scale? So in the next slides, we'll get through a quick overview of UPMC. So UPMC is an IDFS integrated across 4 states, and we have hospitals that range from 10 beds up to almost 1,000 beds, and so quaternary care academic facilities. While a major concentration of our beds is in the Southwest Pennsylvania region, we have grown across Pennsylvania and into neighboring states. We have roughly 90 infusion sites, some of which are dedicated for oncology patients. Some are located within our hospital facilities, and the idea really is that if the patient goes to an academic medical center where the experts are, they could then be treated closer to home, where they may not have to drive all the way back into the city. Advancements in telespecialty models also support this. We're several years into a specialty and home infusion pharmacy joint venture, which also supplies specialty medications for our patients and employees, as well as for other health systems. UPMC also has a robust network of retail pharmacies, And in those retail pharmacies, we provide non-specialty services and also meds to beds opportunities for our patients upon discharge. Our size is a strength as well as an opportunity. We try to leverage excellence across a very diverse network of facilities and patient populations. And in the next slide, Brian will go into a little more of our structure across the divisions.
Thanks, Becky. And where she said our size is a strength and opportunity, it also can provide some challenges, and I'll highlight that here. The numbers on the page you'll see is limited to our pharmacy service line, but to give further concept and identification to those who might not know who we are, as Becky mentioned, we're primarily in Pennsylvania. We provide services in New York and Maryland as well. Over 40 hospitals, roughly 28 billion in annual revenue, half of that equally split between our provider and payer parts of the organization. We have about 95,000 people and roughly 5,000 employed physicians and 2,000 residents and fellows that are rounding in our facilities and becoming the future leaders in medicine as we have it. So very complex and distinct environment. A lot of that would be in the first column you see here in our health services division. That's where we have our hospitals and physician network across, again, that 3-state community that I mentioned. From an inpatient pharmacy need, as you all are highly regulated, we have a very complex challenge in that as we've affiliated with various systems and hospitals throughout the years, we still have 9 EMRs that we're working through, and that becomes very challenging, as I stated on an earlier slide, for standardization and consistency. We're very excited because we're moving to Epic, and that is a very big process for us. In 2 years or so, we'll be there. But that'll help us really regulate and facilitate the change we need across the board. Our ambulatory, Becky mentioned that greatly. Again, as we work to engage and align, being an academic medical center, we have every subspecialty that we can work through. How do we evaluate that and engage that within our ambulatory division to make sure we can maximize the margin across all platforms, again, in the world of financial constraint. Our insurance services division, as mentioned there, again, this is the pharmacy focus aspects of it, but a heavy piece and partner in a world that we live. We have a unique area called enterprises, and this is where we try to leverage and take the brilliance that is at UPMC and find ways to also make us better through this organization and commercialize that where possible. So it's focused in translational science and digital solutions, and there are a couple products that we'll walk through later that you can see some advancement there, and they're laid out here. But we're very excited about our platform. It does provide us strength to move forward, and looking forward to how we continue to do that through the years. As we move to the next slide, I think I'm going to talk a little bit more about financial pressures and sustainability and get a little more details of what we're facing. Everyone's read the national publications on the challenges across the healthcare landscape. We as UPMC are no different. We just released our 2023 financials for the year, and I'll be honest, for the first time in my career, had a negative margin of about 1.5%. So how do we continue to react and adjust to that? How do we balance the changes and challenges across the landscape from a workforce perspective? We've talked about it a little bit in the pharmacy technicians. How do we continue to adapt to that in new ways as wages are continuing to escalate, as the supply of individuals coming in are challenging? We no longer have the luxury to focus on efficiencies when we can, or integration when we can. We are at a point where it's a must, or else we won't be here to continue to provide services for the patients and the communities that we serve. And that is something we're diligently focused on as we continue to move forward. Specifically to the world of pharmacy, how do we react to that? How do we continue to, as I mentioned, leverage the 340B program to its maximum intent within the world and the framework that exists today, realizing it's continued to change? How do we change with it? How do we adapt to make sure we can capture within there? How do we focus on enabling to deliver the care to our patients as care advances? We mentioned the Alzheimer's drugs or various cancer drugs. How do we afford that as providers and payers while still delivering the care? We have to find efficiencies elsewhere to continue those advancements and deliver those cares across the need. So again, if we don't maximize the efficiencies where we can and maximize the profitability where it exists, we are unable to continue the advancements that our communities need us to as we move through the world of healthcare. Go to the next slide. I think I'll transition over to Becky as she'll walk through some of these internal advancements we're looking at UPMC.
Thanks, Brian. So we've had the opportunity to take a deep dive into all of the different facets of our operations and revenue streams. And we're happy to report that we have some successes in these areas, and we will go into some of these in more detail. So we've engaged with partners in looking at our pharmacy revenue cycle optimization, and especially as we prepare to move to one UPMC Epic, we found opportunities in how our drugs were billed and coded according to the CDM. We underwent a vast project in our internal packaging and optimization there. Later on, we'll talk a little bit about vendor and formulary standardization, and then we're always looking for opportunities, as I'm sure you are too.
Yeah, and Becky, as I look at these numbers, they represent roughly 5% of the $1.5 billion that Brian talked about earlier. So these are really impressive. Can you give us a little bit more detail around the vendor and formulary standardization, as well as some other opportunities that you're evaluating?
Yeah, thanks, Jeremy. So we'll get into a little bit of how we've really worked to streamline our formulary and executive P&T structure. And that also includes as we prep and prepare to move from 9 EMRs to one. So lots of work in that space, as well as looking at our automation and supply chain vendors for wholesaler. And then there's other opportunities that we're constantly evaluating.
Great. Thank you.
So as I alluded to in the previous slide, we've been fairly busy in sort of picking up every rock and looking for efficiency opportunities, financial opportunities, economies of scale. As you can see, we've undertaken a lot of very large scale projects, and we weren't really afraid to say, how many vendors are we using in this space? What is the right strategy that we plan to use going forward? At the same time, we've been able to sort of align conversations around our care model, and we will be aligning a new medication delivery distribution model, which we'll get into, to align with changes that we're already planning and in discussion with our nursing colleagues. I want to point out here that we take pharmacy technician and pharmacist workforce very seriously at UPMC. I want to say that, for the first time, we will have a pharmacist career ladder in 2024. We also have pharmacy technicians, and I would say very advanced roles within our pharmacy structure. We have pharmacy technicians that lead our EMR build, pharmacy technicians that will be leading our automation changes, and pharmacy technician leaders that we bring together regularly for how do we really create the right environment that leverages and allows pharmacy technicians to work at the top of their license, which then allows our pharmacists to be closer to the bedside and closer to the patient. And we will get into a lot about what we've done with P&T.
Great. And maybe for Brian and Becky both, this is a lot of change. Just bullets on a slide don't really speak to just how much change this is. And this is just in the pharmacy realm. So how have you guys managed this amount of change at UPMC over the past couple of years?
Yeah, I'll be happy to provide some context, and it's not easy. I think a lot of it relates to embedded in our culture. We have a culture across the organization of wanting to get ahead of change rather than somebody forcing us to change, and that's something that we have inherently built within. Also, I think they're through continued efforts to be more transparent on not just the financials, but everything across our world, the reality of why change is necessary, and that becomes more important. So something along the lines of even the new 340B split biller, well, on a bullet point sounds easy. We had multiple split billers across our organizations. It was very hard to stay consistent and provide the stewardship that we needed of a program of that magnitude. People were aligned around that fact. So I think it's a lot to do with openness of communication and transparency, and a reality that we have to change in order to stay successful.
I'll say in the pharmacy, it's been really easy to align with a lot of the changes that were happening in the organization. So the timing for all of these changes was really wonderful. And, I think just reinforcement and repeating the messages until folks understand has actually been really helpful. So on the left-hand side of the slide, it describes our core guiding principles. And again, this is not just in pharmacy. This is discussions that are had with clinicians and nursing colleagues and finance colleagues. And so we've undertaken a vast organizational change in providing the best care for the most, not the most care for a few, organizing what we do around process versus individuals, building to the rule and not the exception, and really trying to leverage collective resources efficiently versus creating duplications locally or doing the same thing in 40 different sites. Let's just do it once. In the next slide, I describe a little bit about what I alluded to for our medication distribution model changes. So I know the slide is busy, and for the non-pharmacists out there, I'll try to just describe it as simply as I can. So the left side of the slide is what's called a central cart fill model. And really you can think about that as the majority of the medications come from the inpatient main pharmacy. The bullets and the table on the right-hand side is what we call a decentralized cabinet fill model. And you can think about that as the majority of the medications come from the nursing unit. And usually that's arranged as one cabinet or a group of cabinets for every 10 to 15 beds. So usually in a nursing unit, a nurse would have the choice from one side of the nursing unit to the other side of the nursing unit, and those are usually organized accordingly. And there is usually more cabinets in critical care areas, knowing that we have to keep more beds closer to those nurses. There are various differences in the types of distribution models, but I will say at UPMC, the vast majority of our hospitals on the western side of the state operate in a centralized cart fill model, and we will be moving and transitioning to a decentralized cabinet fill model in the future that aligns with changes that are also happening in nursing practice. The next slide highlights a few of the additional differences, and I want to point out here that we actually have seen and done time studies that there is an increase in medication wait times for nursing on the left-hand side. And there's also variation in where do I go for my medication? Is it in the bin? Is it at the bedside? Is it in the med room? Is it in the refrigerator? Which refrigerator is it in? And we found in our sites that employ the decentralized cabinet fill model on the right, there is a decrease in medication wait times for nursing. There's fewer variations in where the medication is, fewer phone calls, fewer baskets for that nurse. And then in future models, we hope to be able to really close up the medication process for the nurse, where the nurse is at the bedside, getting their medications ready, going to the med room once, getting the medications that the patient needs, and really making that a very seamless process. So this is not just about a pharmacy process. This is about how we distribute medications for all of our patients and all of our nurses. This slide talks briefly about what I mentioned about our operational excellence and how we've employed different infrastructure across the organization to really accomplish those goals. So you can see on the very top part of the grid, it talks about the operational excellence governance team. And that is really led by our leaders in the health services division. So this is nursing leaders, physician leaders, legal, finance, pharmacy. We have an executive advisory committee, and then underneath that are the key operational and oversight committees that do the work that try to make it as standard as possible. So two functions of this groups that I will highlight for all of you in sort of what led to our executive P&T transformation was that there had to be changes in how we viewed the medical executive committees and who was making the decisions when. So the Medical Review Council, you can kind of think of that as an oversight committee for all of the medical executive committees. And everything was done in concordance with all of our regulations for the state. And in the Medical Review Council, they've taken a look at different things like bylaws and credentialing and policies so that we can have the same clinical policy across the entire organization. So that change really led for us to be able to set up in parallel changes for the system P&T committee. So we call it an executive P&T committee, whereby I'm the co-chair of the committee. I have a wonderful physician partner who is the chair of our P&T. His name is Mark. I've worked with him since day one, since I've been here. So we've sort of co-created this plan. The system P&T, while it does have subcommittees of all of the different specialties, we do make the finalized decision that doesn't really have the opportunity to be overturned at a local level or a local MEC level. The decisions are final. And in the next slide, I'll describe a little bit about how the different requests get to us. So, in any health system, there's different pathways with which you have to make the decision about what drugs to get reviewed at the P&T committee. So obviously, new medications to the market or first in class, or items that you wish to standardize. And we're very much deep in this process as we prep and prepare for one EMR. We have to sort of go through the different drug categories and say, in this therapeutic class, can we streamline and be efficient and only select one in the therapeutic class versus having several that really do the same thing? We also field and work closely with our pharmacy supply chain colleagues, and if there's an opportunity for contracting or a system standardization, we'll work to put that through. So on the left-hand side of the slide, it describes what we call our chair decision or fast pass sort of lane. And it lays out the reasons and the rubric with which we do those things. So a vast majority of drugs for P&T nowadays really are streamlined to say, this is an outpatient medication. This is a high-cost medication. We make sure that it's ordered by the appropriate clinical stakeholders and the clinical service lines. Most medications really are just reviewed and they're restricted to an outpatient use as long as the patient's insurance covers it. So as I alluded to on the left-hand side of the slide, we do make very quick decisions when needed. If there's a drug shortage, if the evidence is clear, we sort of look at it as not controversial. We're making, I would say, about 70% of our decisions right now through the left-hand portion of the slide. On the right-hand portion of the slide, you can see that there are times where you have to bring folks together. Things are controversial, the data isn't clear, you really need to understand the clinical factors. If something requires a really deep investment in what we're doing in our EMRs, especially because we're using several of them right now, and our IT folks are really focused on how do we get ready for Epic. If something is a significant price increase, then that is handled on sort of the right-hand side of the slide. Moving through, I'll briefly in the next slide be able to show you how well our system P&T structure is really working. I will say it's been in place for about a year, and in my opinion, it's working fairly well. So on the left, you'll see that we did an initiative to standardize our basal insulin. So there was 2 options, and we took it down to 1 option. And the different colors on the slide highlight the various different hospitals. And I will point out that some of our hospitals, really are on disparate EMRs, and there might only be one pharmacist in the facility that can make those changes. And so sometimes there is a lag, and we know that that's going to be part of our process until we get ready for a centralized Epic system. So on the left, every quarter, we do a presentation to all of the sites so they understand where they are, how are they doing, what's the score, what is something maybe they need to take back locally and have a discussion about. Does there need to be more education? Is it a particular provider group that needs education? On the right, we do what's called our formulary designation scorecard. As you can see, very simply, it's green and red. This is shared with pharmacy directors, hospital executives, CNOs, VP of Ops, and it also has visibility to our executive leaders. And it also gives us an idea of how well are we doing in moving initiatives across the finish line. So if I look at a particular initiative, like we did a standardization on anesthesia gases for desflurane, and most of them are green, and there was 1 red blip. And so that gives us the opportunity to say, well, what happened in that facility? In this case, it was actually just an ordering error, so we went back and we fixed it. In an initiative where you see a lot of red, you have to say to yourself, what did we do wrong? Or what happened? Or what's the opportunity there? And that really highlights that that probably was a process opportunity or an educational opportunity versus a one-site, one-off opportunity. Briefly, in the next 2 slides, I will show that we've had some pretty targeted investment in taking a look at our biosimilar medications. And so the first one we'll go over is rituximab. And we started this initiative, I would say, in mid-2022. I think it was September. You'll see a nice change from the dark purple, which is the reference product, and then the teal blue color is the biosimilar. So the goal is to transition the patients that can be transitioned from the dark purple to the lighter blue. And I'll tell you here that a vast majority of our outpatient use of our infused drugs is actually still on paper. So many of these patients were really changed paper by paper, order by order. But what we had the opportunity to do was really create the full infrastructure process of how do we move and manage all the authorizations to a UPMC-owned process versus a physician office-owned process. And this way, we've taken a look at all of our order forms. We made it very simple for providers to basically say, I would like to order rituximab. We then send it to a revenue team that does a patient assessment, figures out what their insurance covers, figures out if the patient has any issues, and then it's forwarded on to the pharmacy, which will then dispense the correct product. In the next slide, you'll see we've also had a similar success with infliximab, which can be a very tricky drug to move your biosimilar marker. And, I will say that in this drug class, different insurance companies have different rules and requirements. So biosimilar A is the medication that's preferred by some of our state Medicaid plans. Biosimilar B is preferred by some of our national plans. And then biosimilar C is the product with which we had the best UPMC contracting. So we always give the patient what their insurance requires because the best drug for a patient is the one that they can afford. And then after that, we will try to maximize our contracting capability if we can. So as you can see, we've been fairly busy in integrating hospitals across UPMC at a fairly fast pace, which helps explain a little bit about the way that we've been standardizing, and we're finally moving to one EMR. And so we'll be able to take on that work of standardization now. In the next slide, I want to talk a little bit about our wholesaler distribution model at UPMC. So we've had, what's been in place is that we had a UPMC internal warehouse that would take drug from the wholesaler and then distribute it to the hospitals and then distribute it to the patients. And as we took a look at that, we really started to wonder, are there certain medications where this makes a lot of sense? And in the next slide, you'll see that we're doing a little bit of streamlining here and thinking about the medications that make the most sense to do this process versus sending it directly from the wholesaler. So we did recently undergo a wholesaler change. And what we're sort of thinking we'll do with the CPSC is that we will really leverage this for strategic purchases or purchases that are low unit of measure or items that are going through our repackaging center, which happens to be at the CPSC. We also centrally manage drugs for the cancer centers and the physicians' offices.
Yeah, and Becky, great points. And one thing I'll add that we see in the marketplace today is these systems start thinking about these consolidated services centers, specifically in pharmacy, as way more than just a warehouse. It's how you manage shortages. It's how you manage the compounding, repackaging. That's where you see a lot of the advantages of driving a lot of the financials that you guys talked about earlier. And I know this is on your roadmap as you're looking at that $120 million target that we talked through.
Yeah, we are exploring. So we have one existing CPSC, and we're exploring other ideas of ways that we can leverage that. And so, you likely, or you may know a health system that has a CPSC. Some surveys out there have stated as high as 64% of health systems leverage and use a CPSC in some format or another. They don't all have the same exact business lines in them. And in our exploration, our CPSCs may serve different functions. They may have a different feel, but really that's based upon the hospitals that they'll need to be serving. So one of the pieces about integration that's important is that all of the different service centers or service lines, really need a way to be anchored to all of the different layers of executive leaders. So in this picture, you can see that on the right-hand side of the slide, we've decided at UPMC that the site operational leader, so in this case, if it's pharmacy, they'll have a straight line report to their vice president and then up to their hospital president, and then a dotted line to the service line. And so where it says service center dyad, that's me in this picture. And then I co-manage the pharmacy services with a physician leader. And so then, we report up through the health services division, but then we have also other service lines to rely upon that are also doing the same thing. So it's really made a lot of sense in how we've begun to organize how we work together.
We'll talk a little bit about investing in the future. You've heard Becky mention automation. We're working through the creation of the central and coordinated service centers, investing in the mail order and freestanding infusion sites. The couple areas that are missing from here that I would also consider investments, we're evaluating the workforce. The career ladders within the pharmacy technicians is a definite investment that I think is worth it almost as much, if not more, than the infrastructure we're talking about. Also the EMR. I think Becky has mentioned it at least 9 times. I use the word 9 because we have 9 EMRs. But also that alignment will provide such an efficiency across our network to continue some of these advancements. Also infrastructure. I don't know if your entities were like ours, but you tend to invest in what's outward facing or what's the most fun new toy at times, and that always isn't in the world of pharmacy. What we've talked about here is the infrastructure of the organizations is really what is going to help us drive continued change and improve the financial results. So reinvesting in our pharmacies from an automation standpoint, from a USP compliance, and as some of our more historical locations need to be renovated and reinvigorated, how do we make sure we do that in whatever the rules and regulations are at this point? Those are areas where we continue to invest and ensure we are maximizing how we deliver pharmaceutical care across our organization to meet the needs of the patients, again, where we need to. If you go to the next slide, if you could. UPMC Enterprises. I mentioned this previously with a focus on translational and digital solutions. This is an area that I'll be honest, when UPMC first went down this pathway, I said, what are we doing? Why are we taking money and investing it in this arena? And boy, I'm glad we did, because it's an area that has been tremendously helpful from reinvigorating our organization around different thought process and different solutions. Also engaging capital into the organization from outside sources and outside areas, and how we reinvigorate and take what we do from a best practice perspective and create portfolio companies that we see an issue, and we can leverage our best practice to create a solution to that issue and invest in that. And then others want to do it as well. And these are examples of how we've done that successfully in partnering with CarePath around our specialty pharmacy solution, Arrive Health for better connection and contacting patients. And there's many others that are our enterprise solutions across not just the pharmacy arena, but across our continuum of healthcare, is continuing to provide advancements that allow us to not only improve the delivery of care, but also the financial ability to do so with some of the returns and infusion of capital from a venture standpoint. So it's been tremendously helpful and beneficial. If we go to the next slide, Becky will actually give us some examples of one of those portfolio companies.
Thanks, Brian. So we had the opportunity for our Meds to Beds program, and that is that is now a joint venture that we work with Arrive Health that was on the prior slide. But we were able to do an in-depth study at UPMC to show the value of our internal retail pharmacies in providing medications to patients before they left the hospital facility. As you can see on the right, we showed a 32% decrease in 7-day readmissions, and below that, a 16% decrease in 30-day readmissions. So in addition to being partners, they also help us in driving the outcomes that we need to really build the programs that support our patient needs.
The role of partnerships is something I can tell you we at UPMC have changed our perspective on over the years. I think initially, as we were growing up as an organization, we thought we could do everything everywhere and better than everyone. And as the variables around healthcare have changed, as the geography of our footprint has increased, as the competitors have become more around us, whether it be from an Amazon or whatnot, we have realized that we can't do it all ourselves. And the engagement from a partner perspective, whether it be along the lines of what I mentioned in enterprises or finding the right consultant to help bring a different perspective to what we're doing, because as we're doing it every day, our glasses and narrow point of view is focused, and bring those folks in to have additional bandwidth, technical expertise, whether it be a second opinion or seeing it again from not colored lenses, is tremendously helpful in allowing us to move forward. They can highlight complexities they've seen in other organizations. They can bring in examples of how there's been successes and also failures that we don't have to do on our own, and learn from others' pathways forward. Those are all areas that we have grown and learned, and now looking to find the right partner. I think it's also key to make sure we always don't rely on someone else. We leverage who we are, but partnering and engaging with that and supplementing that with the right individuals to help us continue carry forward, not only at the right pace, but the right time. I think if we look at it, there's a three-legged stool, if you will, and you can do anything with that. It's time, it's people, and it's money. If you have those things working, and you can do it with 2 of those and still balance, but the minute you don't have that, things are going to fall apart. And how do you engage the right partners to balance those, that tripartite there, to be able to move us forward? That's really the key, because at the end of the day, if we can't continue to advance, we can't continue to drive margin, we can't continue to sustain and deliver our mission. And that's where we continue to try to drive and focus. And if we go to the next slide, and really our last one, I hope these are the key takeaways you take from this presentation. These are what we meant to represent, and I think we've done our job. So,
great. Thank you both for that. Maybe just a couple questions to round out the presentation today. And the first one, Brian, maybe directed at you. Regarding the financial sustainability, how do you see the pharmacy enterprise continuing to drive the positive income for UPMC?
Yeah, Becky highlighted it on a previous slide with some of the areas of opportunity we're working in within our organizational structure. I'd say no matter how many times we think we have corrected things or find the efficiencies or advancements, the world has reset. So always go back and make sure you've risen that bar, whether that be from a contracting standpoint or, like we have just done, move to a new wholesaler and reevaluate those historical relationships. Those are areas of opportunity. The continued world of specialty pharmacy, and how do we continue to capture those scripts and that opportunity as we continue to move forward. Becky also mentioned the redesign of what our historical pharmaceutical delivery model was. It worked. Why would we change? Well, we changed because we found it to be more efficient, more effective in the delivery model, and I'll call cutting out the middleman at times, then did save us that opportunity and availability there. So as we continue to move through what I will call the supply chain operations, the availability of contracting, and the leveraging the economies of scale that we are really where I see the areas of focus around the world of supply chain and pharmacy. Great.
And I'll end with one final question for both of you. It's often everyone's favorite question, and you guys have taken us on a presentation today, a great journey over the past couple of years. If you were doing it over again, what would you do differently?
Becky, do you want to go first?
Yeah, I'll take a first pass at that. I think that you've got to sort of manage your impatience, which I've been known to be fairly impatient, and sort of wait for the right time to bring up the right opportunity. And I've been lucky to have such amazing leaders to work with at UPMC, and just really learning to sort of trust that that timing is coming and be able to take advantage of that opportunity when it does.
Yeah, and I'd add to that. I sort of hit on it in my last comment on partnerships. Adapt and adjust. What worked for you yesterday is not going to work for you today. And how do you realize you need to reset those expectations and reevaluate where even you thought you were best practice? And how do you continue to move through that? Don't be afraid to say that maybe you aren't, and maybe we do need to engage others in that solution. And honestly, for us, I think engaging a little earlier would be how I'd go backwards in time to restate the world as to your question. But I think really continuing to reevaluate yourself is how I'd state that, Jerame.
Right. All right. Well, I know we're about at time, and thank you both for your time today. It was great to talk to you.
Thank you.
Thank you. Well, that's all the time we have for today. I want to thank Brian, Becky, and Jerame for an excellent presentation today, and also to Visante for sponsoring today's featured session. Thank you again for joining us today, and we hope to see you at future Becker's virtual events. Have a great day.